My name is Captain Ganshert from Triple Army Medical Center. Thank you for the opportunity to present today. Today I will be talking about the differential effects of crystalloid compared to whole blood in early phase resuscitation on extravascular lung water and the development of acute lung injury in an experimental porcine hemorrhagic-reperfusion model. I have nothing to disclose, and my views do not represent those of the Department of the Army, DoD, or the U.S. government. In Afghanistan and Iraq, hemorrhage has accounted for 90.9% of pre-hospital and 80.1% of in-hospital deaths from potentially survivable injuries. This has led to the goal of patients receiving hemorrhage control and resuscitation during the golden hour and more forward deployment of medical assets to improve pre-hospital mortality. With patients surviving their initial injuries, morbidity and mortality related to their initial resuscitation and fluid management are becoming increasingly important. Complications specifically related to resuscitation and trauma include acute lung injury and acute respiratory distress syndrome. Focusing on the lung, acute lung injury is a serious complication in the critically wounded soldier, carrying up to a 30% mortality rate. It is a cycle that begins early in the casualty with dysfunctional physiology, disruption of the endothelial epithelial lung barrier, inflammation, neutrophil migration, increased permeability, and extravasation of fluids, finally resulting in impaired gas exchange and hypoxia. Over the past 2 decades, changes in resuscitation have supported permissive hypotension, balanced transfusions of whole blood, avoiding crystalloid, and other measures, including warming and TXA, to prevent coagulopathy and ultimately death. However, unintended side effects of this transition towards blood products and whole blood may include an increase in acute lung injury. A 2012 retrospective analysis of patients undergoing massive blood transfusions at combat support hospitals found 11.2% with acute lung injury, and of those, 34.4% had received whole blood. They found warm, fresh whole blood to be independently associated with acute lung injury, although this may have been confounded by increased injury and crystalloid use in those patients. To further investigate this, we examined the effects of whole blood and crystalloid on extravascular lung water in an experimental porcine model. Our model uses 10-kilogram pigs, which were anesthetized, intubated, mechanically ventilated, and catheterized in the pulmonary artery, internal jugular, femoral artery, and vein. After a period of stabilization, they were hemorrhaged at a fast rate followed by a slow rate for an approximately 40% total blood loss. They were then allowed to stabilize before receiving resuscitation with either normal saline or whole blood, with data collected at pre-specified intervals. This illustration depicts our timeline. Resuscitation was given back in units equal to the amount hemorrhaged, referred to as shed volumes. Additional shed volumes were given for persistent hypotension. The consequences of resuscitation were assessed by measurements of blood pressure, cardiac output, arterial oxygenation, pulmonary artery pressure, extravascular lung water, and wet to dry lung ratios. Extravascular lung water volume was measured using a thermal dilutional technique. Our hemorrhage model induced significant hypotension and decrease in cardiac output. MAPS fell a significant 38% on average. Cardiac output also decreased by 27% post-hemorrhage. We saw an increase in the ratio of the pulmonary vascular resistance compared to the systemic resistance, a marker of pulmonary dysfunction and hypertension, while pulmonary artery pressure remained the same, showing that this change was not due to heart failure. In terms of pulmonary dysfunction, we were able to achieve relative pulmonary hypertension, looking at the pulmonary vascular resistance over the systemic resistance, as shown previously, and an increased physiologic oxygen demand, as shown above by the VO2 max. Here we see that the effects of hemorrhage on VO2 max and the ability of whole blood, shown in red, and crystalloid, shown in blue, to return to baseline. Both groups had a significant decrease during the hemorrhage, and both were able to return to close to baseline, although we do see a trend for whole blood to be able to do this more quickly and a larger magnitude of effect. Looking at 13 different serum markers of inflammation, Here I highlighted 3 important markers predictive of ALI and ARDS, IL-6, IL-8, and tumor necrosis factor alpha. We did not find a significant difference between the different resuscitation fluids, although it should be noted that our whole blood cohort had increased cytokines relative to crystalloid at baseline, and that this magnitude of change was not significant. Similar results were found for the other 10 markers. After our intervention, we found that both whole blood and normal saline were able to adequately resuscitate the pigs. Significant differences were found in the ability of whole blood to restore MAP compared to crystalloid, and also a significant increase in pulmonary artery pressure. In our model, we found that 3 shed volumes resulted in volume overload and cardiac collapse in our pigs, and thus limited our resuscitation to 3 shed volumes. Another important difference to note is that the whole blood returned blood pressure to baseline with 1 shed volume on average, compared to an average of 2.17 shed volumes of normal saline, with a tendency for a smaller magnitude and durability effect in the crystalloid group. This was a significant difference. Comparing the overall lung water content of the lungs and their wet to dry ratios, we found no significant difference between whole blood and normal saline, although this may have been in part due to limitation of our methodology, as the lungs were not exsanguinated prior to harvesting. Using the thermodilutional method, we were able to look at the distribution of that lung water. We found that more water was located in the extravascular space as compared to the intravascular space. Comparing baseline to the next 3 hours of resuscitation, we found a significant increase in extravascular lung water, with increasing but non-significant tendency for crystalloid to have larger extravascular lung water compared to whole blood. With increasing shed volumes, we did not find a significant increase in the extravascular lung water, but this may have been due in part to our small sample size and a survival bias found in the remaining crystalloid pigs. Those that received more tended to die. In the early phase, within 4 to 6 hours of hemorrhage, followed by resuscitation, we found that crystalloid resuscitation has a tendency towards increased extravascular lung water as compared to a whole blood resuscitation strategy. PaO2 to FiO2 ratio did not decline significantly, suggesting that no clinically significant pulmonary edema or lung injury occurred. However, a longer study period, 24 to 48 hours, in the future may be able to show this development as it progresses. Our experiment will allow us to further develop this porcine model of acute lung injury, allow us to look at the results beyond the early phase of resuscitation, and further investigate the role of EVLW in resuscitation. We would also like to investigate other treatments, such as artificial blood and freeze-dried plasma. Thank you. Goodbye.